insulin deficiency. It's autoimmune. You know all this. And insulin treatment is really an absolute necessity. Unless type 1 diabetes develops later in life, and in that situation you can get latent autoimmune diabetes, and you don't need insulin initially necessarily, but I'm getting off subject here. Type 2 diabetes, is this a deficiency disease? Doesn't look like it. This is a pair of patients who were treated by a colleague of mine. They were known as the motorcycle twins for obvious reasons. They made their living going around county and state fairs and performing tricks on their motorbikes. They were identical twins and developed diabetes within 5 years of each other, which is the case in 90% of type 2 diabetes with identical twins. But believe it or not, there is a deficiency of insulin. As Adi referred to earlier, there's both impaired insulin secretion, beta cell function, and there is impaired insulin action or insulin resistance. So the insulin secretion, also referred to earlier, loss of first phase insulin secretion is the first thing that we see wrong. Excuse me. And then there is progressive loss of insulin response and an inadequate response relative to insulin action. Adi also showed this slide earlier showing you that when your fasting plasma glucose has gotten to about 100 or higher, then you lose this first phase insulin. You can see that the black line with the subjects whose fasting glucose was 100 to 114 had already lost at least 50% of their first phase insulin response. And then the insulin action, of course, we do have impaired insulin action, and this just emphasizes that, showing you the decreased or the resistance to insulin action at both the hepatic level and at the muscle level. And this is from a study of Pima Indians showing that looking at people who did not progress when they had impaired glucose tolerance. Sorry, let me get this wrong. This took Pima Indians with normal glucose tolerance and followed them prospectively for a number of years and divided them into two groups: those whose glucose tolerance remained normal, and that's shown up in the purple. And you can see that those patients, as their insulin sensitivity decreased, their beta cell function was able to compensate, so they moved up on that line, whereas the ones who started off with normal glucose tolerance but progressed to impaired glucose tolerance and then to diabetes, they had really a rather catastrophic or at least significant decrease in their insulin secretion or their beta cell function. So ultimately, it is the decrease in beta cell function which leads to type 2 diabetes, and therefore it's no surprise that this continues after the diagnosis of type 2 diabetes, and that eventually insulin treatment becomes a logical consequence of long-standing type 2 diabetes in many patients. I'll not labour this slide, which has been shown at least twice before, just showing the time elements here and the decreasing insulin levels. So the principles for success of treating any patient, treat the whole patient, and in particular in diabetes. Over the last 10 to 15 years, I think endocrinologists in the United States anyway have become much more successful in turning themselves into holistic diabetic doctors, not just looking at glucose, but also looking at blood pressure, lipids, etc. Whereas when I got interested in endocrinology way back in the 1970s, it was pretty much a glucocentric disease. A second thing is follow national standards of care and additional therapy as needed. And as I say here, many patients will eventually need insulin because of the progressive loss of beta cell function. So while I have emphasized, they follow national standards of care, and these just give you these standards, and we've gone over those earlier. Here are the ACE goals. So I think A1C of 7% has been mentioned. You may know that there is a fairly vigorous debate in the United States as to whether the 7% should be the target or 6.5%, or even in some patients, whether you should be trying to get A1C absolutely normal. Or in other patients, maybe even aiming for 7% is too strict. And I'm sure that this will come up later in today. Now, as I've said, additional therapy is often indicated. Many patients cannot be maintained at satisfactory A1C levels on only 2 oral agents, and therefore you may need to decide, well, should we add in a 3rd oral agent, or would it make sense to add in insulin? And in the United States, it's actually, in practice, the reason that family practitioners and internists refer patients with diabetes to see endocrinologists like myself is virtually always because of the glycemic control. I've just said that we've been, as endocrinologists, we've become much better at managing and looking and thinking about the blood pressure and the hyperlipidemia. But in fact, it is usually the hyperglycemia that seems to stump. And I'm glad to be in India, where I can use a cricket analogy, because that is not so well understood in America. And I could, of course, veer off and say it's amazing to me that Americans can't understand cricket when they can appreciate such a moronic sport as baseball. And I'm glad there aren't any other Americans in the audience. But anyway, say we get asked to see patients because of hyperglycemia. It's not so much that we're asked to see them because of the hyperlipidemia and the hypertension. So if you look at physiological insulin secretion, we're always producing a small amount of insulin, even when we're not eating. You need some insulin to restrain the hepatic glucose production. Otherwise, you will get fasting hyperglycemia. But you get these large increments of insulin occurring very rapidly whenever you ingest food, as illustrated on this slide. Okay, so you can think of, if you like, in someone who's taking 3 meals a day, you can think of a sort of basal insulin secretion, which is represented along the bottom of this slide by the lower line of the box that has been put in, and then the mealtime insulin represented by the arrows. Adi showed earlier that in type 2 diabetes, you do tend to get a rather steady decline in beta cell function after the diabetes has been diagnosed. Of course, our common practice tells us, our common experience tells us, that not everyone declines in their beta cell function at the same rate as everyone else, and I've got many patients who have never needed insulin during their life with type 2 diabetes, and I have other patients who have required insulin rather soon after being diagnosed with type 2 diabetes. It's worthwhile remembering that a proportion of patients who are diagnosed with type 2 diabetes actually turn out to have latent autoimmune diabetes. And if you're not getting this, I think is a good learning point. If you're not getting good control, the sort of control that you would expect to get with 1 or 2 oral agents, think of the possibility that you might be dealing with a patient who has latent type 1 diabetes. It's more common than people realize, certainly in America and in Western Europe, and I suspect that the figures would not be that dissimilar here. So, initially, if we are going